Hello, my name is Dr. Richard Kijowski, professor of radiology at New York University Grossman School of Medicine. I would like to give a brief presentation on MRI of cartilage lesions, how I report it. I would like to first give a short PowerPoint presentation describing how I dictate the appearance of cartilage lesions in my report, and then illustrate using multiple case examples. Now, the MRI appearance of a cartilage lesion depends on whether the lesion is post-traumatic or degenerative in origin. Post-traumatic cartilage lesions include a cartilage flap tear, cartilage delamination, and a focal full-thickness cartilage defect with perpendicularly oriented or acutely angulated margins. Degenerative cartilage lesions include basal cartilage degeneration, in which the superficial articular surface remains intact, but there is degeneration of the underlying transitional deep zones of cartilage, which is manifested in an MRI as focal areas of increased signal intensity on T2 weighted images. Other forms of degenerative cartilage lesions include cartilage fibrillation, consisting of irregularity of the articular surface, cartilage fissuring, and focal cartilage defects with obtuse margins. When describing a cartilage lesion in your dictated reports, I think it is very important to describe the exact depth of the cartilage lesion. I use the noise classification system for this purpose, in which a superficial partial thickness cartilage lesion is less than 50% of the total depth of the cartilage. A deep partial thickness cartilage lesion is greater than 50% of the total depth of the cartilage. And a full thickness cartilage lesion is 100% of the total depth of the cartilage. Now, in addition to describing the depth of the cartilage lesion, I think it is important to describe the exact location of the cartilage lesion. The International Cartilage Repair Society has developed the cartilage map, which divides the articular surface in multiple regions. However, I believe this cartilage map is much too advanced in order to be used in clinical practice, and I have developed the abbreviated form of this cartilage map to use to describe the exact location of a cartilage lesion on each articular surface in my dictated report. For the patella, I divide the articular surface into the median ridge, medial facet, and lateral facet, and then further divide each region into superior and inferior subregions. For the trochlea, I divide the articular surface into the medial and lateral trochlea, and then further divide each region into superior and inferior subregions. For the femoral condyles, I divide the articular surface into weight-bearing and posterior portions. The weight-bearing surface is located between the anterior margin of the anterior horn of the meniscus and the posterior margin of the posterior horn of the meniscus, while the posterior portion of the femoral condyle is located posterior to the posterior surface of the posterior horn of the meniscus. I further subdivide the weight-bearing surface of the femoral condyles into anterior and posterior subregions. For the tibial plateau, I divide the articular surface into anterior, central, and posterior subregions. Now, in addition to describing the type of cartilage lesion, the depth of the cartilage lesion, the location of the cartilage lesion in my dictated reports, I also describe associated findings of cartilage lesions, including bone marrow edema lesions, osteophytes, synovitis, and intra-articular bodies. Now I would like to show you multiple case examples of cartilage lesions in real patients. I would like to first start off with traumatic cartilage lesions. This is a nice example of a cartilage flap tear. I would describe this as a superficial partial thickness cartilage flap tear on the lateral patellar facet. Now, a flap tear is a fluid-filled defect within articular cartilage, which courses perpendicular to the superficial cartilage layer and then courses obliquely or tangentially through the transition and deep layers of cartilage. Now, cartilage flap tears are important to describe in your dictated operative report because these cartilage flaps have unstable flaps along the superficial surface and may cause symptoms as the unstable free edge of the flap impinges against the opposing articular surface during knee range of motion. Now, this case shows a nice example of post-traumatic cartilage delamination. Cartilage delamination is manifested in MRI as a thin, fluid-filled linear area at the junction between the cartilage and subchondral bone. Now, histologically, cartilage delamination occurs at the junction between the calcified cartilage and the adjacent subchondral bone, which is the weakest link in the cartilage bone unit and is most prone during trauma. Cartilage delamination is typically caused by shear injuries or shear injuries to articular cartilage, as in this case. And the cause of this patient's cartilage delamination is transient patellar dislocation. Notice the patella alta, the dysplastic trochlea, and the lateral subluxation of the patella in this individual, with an associated intra-articular cartilage fragment in the lateral suprapatellar pouch. Now I would like to discuss the appearance of degenerative cartilage lesions on MRI. This first example of a degenerative cartilage lesion is a cartilage fissure. I would describe this as a full thickness, obliquely oriented, fluid-filled cartilage fissure on the lateral patellar facet. Now, the difference between cartilage fissures and cartilage flaps is that in cartilage fissures, the defect between the articular surface cartilage is much thinner than in a cartilage flap, and a cartilage fissure is not associated with a free edge, which is unstable and loose. Now, this case shows another example of a cartilage fissure. I would describe this as a full thickness cartilage fissure on the central weight bearing surface of the medial tibial plateau with an underlying bone marrow edema lesion. Now, this cartilage fissure appears of low T2 signal intensity as opposed to the cartilage fissure in the previous example, which had high T2 signal intensity. In my experience, most cartilage fissures that I see in clinical practice consist of linear areas of low signal intensity extending through cartilage. Now, the reason why they are low T2 signal, these cartilage fissures, is that the gap between the cartilage is not wide enough in order for enough free fluid to instill within the defect and be visualized as bright signal on T2 weighted images. Instead, the cartilage fissure is manifested as linear areas of low T2 signal because the surrounding degenerative cartilage is associated with collagen denaturization, and collagen denaturization increases the binding sites for water on the collagen macromolecular matrix, which results in an increased fraction of bound water and a reduced fraction of bulk water, which results in a decrease in T2 relaxation time and low signal intensity on T2 weighted images. Now, this case example illustrates a degenerative focal cartilage defect. I would describe this as a focal full thickness cartilage defect on the central weight bearing surface of the medial femoral condyle and a deep partial thickness cartilage defect on the central weight bearing surface of the medial tibial plateau. Now, for evaluating the exact depth of the cartilage lesion, I think it is most useful to utilize the fat suppressed and non-fat suppressed intermediate weighted fast spin echo images rather than the T2 weighted image. On the T2 weighted image, the echo time is so long that the deep cartilage layer has no signal whatsoever, and it cannot be distinguished from adjacent subchondral bone. The lower echo time on the intermediate weighted image results in a greater amount of signal within the deep cartilage layer and better differentiation between the deep cartilage layer and the adjacent subchondral bone, and a more accurate estimation of the thickness of the cartilage defect. Now, in this last case, this is a nice example of diffuse cartilage loss. Now, diffuse cartilage loss is a very common findings of advanced cartilage degeneration, typically associated with radiographic evidence of osteoarthritis. Now, as cartilage degeneration progresses, multifocal focal cartilage defects coalesce into large areas of cartilage loss. I would describe this as deep partial thickness and full thickness cartilage loss diffusely present along the weight-bearing surface of the medial femoral condyle, with associated superficial diffuse cartilage loss on the weight-bearing surface of the medial tibial plateau. Now, when evaluating for diffuse cartilage loss, I think it is very important to look at the coronal images because it allows you to assess symmetry of the thickness of the articular cartilage in the medial and lateral compartment. Now, individuals' thickness of the cartilage varies greatly between individual to individual. So when you look on sagittal images in only one compartment, it may be difficult to appreciate whether or not there is thinning of the cartilage. However, the symmetry allowed by the coronal images can nicely illustrate differences in the thickness between the medial and lateral femoral condyle. In addition, it's very important in this patient to describe the extensive bone marrow edema lesion underlying the diffuse cartilage loss on the medial femoral condyle. It is important to discuss or describe bone marrow edema lesions as they are associated with knee pain as well as the progression of cartilage degeneration. When there is a large amount of bone marrow edema underlying a cartilage lesion, as in this case, it is very important to closely look for a fracture line in order to distinguish a degenerative subchondral bone marrow edema lesion from a subchondral insufficiency fracture, which is common in individuals with cartilage loss and especially meniscal extrusion in this case. Fortunately, this patient did not have a fracture line, which I could detect. So this is my last case, and I hopefully this lecture was helpful for you and how to describe cartilage lesions on MRI in your dictated MRI examination reports. Thank you for your attention.